All right. Thank you, everybody, for joining us here today for this policy forum, the first policy forum that the McKell Institute really has done in person since the end of the lockdowns that we've had here in Victoria. So I'm quite excited, to be honest, to be out and about and doing things in person here again. So thank you very much for joining us. My name is Ryan Batchelor. I'm the Executive Director of the McKell Institute here in Victoria. For those of you who may be not familiar with our work, we're an independent, not-for-profit research institute, what many of you may know as a think tank, whose mission is to engage in public policy debate, particularly here in Victoria to look at Victorian issues, but we've got offices in Sydney, Brisbane and Adelaide, so we obviously think about issues amongst the states and also at a national level. And one of the things that we're really interested in is how we can think about innovative solutions to contemporary public policy challenges, and that's our overarching mission, and one of the reasons why we're really interested in engaging in today's debate. Can I begin by acknowledging the traditional owners of the lands we're meeting on here today. We're meeting on Wurundjeri country, and I'd like to pay my respects to elders past and present, and to acknowledge the continuing role that the Wurundjeri people have in caring for this country, and the important role that they and other Aboriginal Victorians are playing in what I think, for those of us who may be watching this presentation later or joining us from interstate, the really leading way that Victoria is taking forward its relationship with its First Nations people through the treaty and truth processes that are underway right now. And I think it's important in forums like this to acknowledge that there's a lot of really interesting and important work being done to both recognise, tell the truth and heal, and think about how we take the relationship that we have with our First Nations people forward. I also wanted to, before I introduce today's panel and speak a little bit about what we're going to be talking about here today, also to acknowledge that it's International Nurses Day, and a good day to be talking about what the future healthcare challenges are. So we probably also should say thank you to all the nurses out there, those of us who are joining us here today, and I'll introduce Kirsten in a minute, but to the others who've been working tirelessly throughout this pandemic. Just a couple of housekeeping matters as well. There's sandwiches and food at the back, tea and coffee facilities. Please feel free to eat. We want to make sure that you guys aren't sitting there on an empty stomach and letting those tasty sandwiches go to waste. There's bathrooms out outside the front door. We are recording today's proceedings because we want to have a record of the conversation. We think for those who couldn't make it here in person today, it's a good opportunity. If anyone's concerned about that, come and talk to us. There's collection statements that are on your table. So if you want to get up and ask a question, you'll be captured on camera. So just understand that. So we've joined by some important voices here today in this conversation, really to bring a diversity of perspectives. And so I thought I might introduce the panellists to you from, I don't know whether that's left or right from where you're sitting, but from this end to that end. Kirsten Davidson is joining us. Kirsten's an experienced clinical nurse consultant at the Royal Children's Hospital, working as both a nurse and a nurse educator, working on the EMR and informatics team. For those of you like me who find the world of acronyms bewildering, Kirsten, I assume that's electronic medical records. That's right, good. She also has a clinical nursing role working across a number of specialist teams. So we're interested in getting her perspective from both of those here today. Beside me is Dr. Roderick McRae. Dr. McRae is a consultant anaesthetist and intensive care physician at Monash Health, and also, interestingly and importantly for today's discussion, the Victorian president of the AMA, and holds a long list of other important jobs, and which I won't go through in detail, but to understand that both from a practicing clinician's perspective, physician's perspective, but also as a representative of the medical profession, and engaged in a number of key health policy bodies. We're really interested in the conversation and the contribution that Roderick will bring today. Sitting next to me here is Dr. Angela Jackson. Angela is the lead economist at Impact Economics, a health economist who's served previously for 6 years on the board of Royal Melbourne Hospital. So has got some views from a governance and academic perspective, I should say, although a practical academic, I would say, rather than a... and Angela, I should declare that Angela and I worked together previously in a previous life when she was the Deputy Chief of Staff to the Finance Minister in the Commonwealth Government some years ago. And Brett Newstead is a director with Zebra Technologies here in Australia, and in that role he advises healthcare providers on how they can efficiently address the key issue of healthcare worker fatigue by using mobile technologies and to digitise processes to facilitate better outcomes in healthcare. And from the McKell Institute, we're really proud that Zebra Technologies is partnering with us to bring today's discussion to you. So we want to thank both Brett for participating, but also Zebra Technologies for helping us put on today's discussion. Basically, the format today is that I'm going to ask each of the panellists to say a few words, give a bit of an introduction on the theme about what are the challenges facing the Victorian healthcare system beyond the pandemic? What's coming next? What do we think those challenges are? And how do we deal with them? By way of scene setting, I think that we're certainly meeting for this discussion at a very interesting time. I think from our perspective, when we put some of this in the material, there's certainly what we're seeing post-pandemic is a real surge in demand, in healthcare demand, both from the pressures that accumulated and the issues that are facing us as a result of the pandemic itself, but then also the impact that deferred treatment, people's inability to access the system during periods of lockdown or reprioritisation, and what that's meaning for patients. The other big issue I think that we're facing is on the staffing side, that healthcare workers, both everyone from the consultants, the doctors, the nurses, through to the other types of orderlies and other support staff that work in our hospitals, have just been doing a Herculean job in the last couple of years, and we are seeing more and more stories in the paper today and previously about the impact that that's had on our healthcare workforce, and so I think there's a real challenge there in figuring out how we deal with that. And the other issue I think that's confronting us is that there's budgetary pressures that across the board, both here in Victoria but also nationally, there are pressures on our government budgets, there are pressures on health budgets, and figuring out how we deal with those challenges and how we make sure that the system is able to deliver what the patients need as we move forward in a complex and challenging fiscal environment is another thing which we I think is worth considering and worth discussing. That's kind of all I wanted to do by way of scene setting. There's obviously been a lot happening contextually here in Victoria with the Victorian state budget. I'd say a couple of weeks ago. We've got a federal election in 10 days' time. That's coming very soon. So there's a lot happening, there's a lot going on. And what I want to get out of today and what we want to get out of today is a really interesting conversation amongst our panellists, but then also from you, the audience members, with a bit of Q&A after we've had a bit of a discussion up here. So we'd really encourage you to be thinking about some of the questions that you might like to ask us as we take this discussion forward. So I might start, Kirsten, if I can, by getting you to pick that microphone up. And maybe you can just give us, I don't think you don't need to do anything to it. I think it works perfectly. That's the theory anyway. If you can just maybe give us a perspective from where you are as a nurse, as a lead nurse, on what your experiences of the pandemic, how you think the system has coped, how it's adjusted, and what you think some of the challenges that we're facing going forward are.
Yeah, definitely. So I work on a busy surgical unit as part of my clinical role. I've done that for over 25 years. So I've seen healthcare change in that time, and our families and our patients. From a nursing perspective, the pandemic has put a big spotlight on the value of nurses in the system. And also our families and the community are really valuing nurses and the impact nurses have in care. But possibly our hospitals and the machine of public health really doesn't show that we really value those nurses in a way by the environment we're working in. And that might mean that potentially we don't have the right tools. What do we need to enable us to deliver good care? We really need to be able to really have that time to care. And how do we help nurses to release them from low-value tasks, tasks that take time, documentation that's not effective, processes that aren't required, really, that don't enable me to be at the bedside and deliver that care that those patients and families deserve. And from a healthcare perspective, from me, from a clinician, I feel torn when I can't provide that care that really is expected of me to be able to be provided for my patients. From an EMR perspective, so I have an interesting other role from an EMR and an analytics perspective. How are we using the EMR? We've had an EMR since 2016 to enable efficiencies to release nurses for that time to care. But also, on International Nurses Day, which is the theme is nurses, a voice to lead, how are we enabling nurses to have nurse-led care, to create capacity in the system? So we're sort of transformed some of the way we care in the pandemic, but we haven't gone the full way. There's so many opportunities to have nurse-led care, to release nurses, to be enabling care. Can we care for children closer to home? Can we have recovery methods at home where a nurse does a follow-up call to create capacity in the hospital? I think there's lots of ways nurses will know how to fix some of the things in the system to create capacity, especially in public health, but also how do we use technology and the data we've collected to have predictive models of care? What informs our care? How do we use the EMR and informatics to say, okay, after day 2, this is safe for this patient to be transitioned to home? We've got data since 2016, but we're really not tapping into that. As part of our efficiencies at the Children's, we introduced a handheld mobile device that enables nurses to document at the point of care. And we've had some really great satisfaction from nurses. They're happy because my care is enabled. I can document at the point of care. I don't have to go outside the patient room to find a computer and log on and do the care I need to do or document the care. They have this device that enables scanning for safety. We're keeping our patients safe with the device. And we've leveraged all the elements of our EMR to enable those nurses to be much more efficient at providing care. But we actually had to have insight and a strategy for nursing. We had to say we want our nurses to be mobile. We want our nurses to be able to provide care at the bedside, in the car park doing those immunisations, collecting those specimens, and also in the home. And we're using that one device to enable that as well.
Thanks, Kirsten. Roderick, if I can ask you next, from where you sit with both of your hats on, I suppose, as a clinician and as a leader in the healthcare system, what do you think some of these key pressures are that we're seeing right now in healthcare?
Yeah, thank you. And first, I'd like to also pay my respects to the elders past, present and emerging, and the custodianship of the land upon which we meet, and also express my gratitude on International Nurses Day. Even in Kirsten's presentation, there's just so much we could talk about. Some would be controversial and others would not. So to perhaps summarise, we're in the middle of an unbelievable disaster and we're having a nice lunch. And that's part of the difficulty, because everybody is trying to wish away a global pandemic. You know, if I said, put your hands up if you think it's all gone and finished, I would hope nobody moves, because I can't overstate how stressful it is. Because it's a crisis, it seems such a shame to waste it. So AMA has done a lot of work with government trying to improve things, and it's across, we picked 4 key areas: primary care, or you'd know it as general practice; mental health, and that's across public, private and everywhere in between; the catching up with the lack of patient care, and I can assure you at the end, in 25 years, the number of people who've had significant mortality, or well, morbidity I should have said, mortality being very significant, and mortality as a consequence of their deferred care or something they didn't reach is going to way outnumber the people who have certainly died from and even had significant morbidity, perhaps as we translate a little bit into long COVID, going to completely outnumber it. And then there's the public hospital system itself. And we very much support the Victorian State Government's budget initiatives. There was a lot of money, $12 billion. That's playing catch up for, I've been in the system 35 years. I know I only look like I'm 27, but throughout that time, there's been a lack of investment and capacity. We champion migration. We welcome the doubling of the population of Melbourne, for example, over the last 8 to 12 years. We haven't doubled the hospital capacity. We've relied on people like Kirsten and myself to run the hamster wheel that little bit faster. So 20 years ago, if you came in to have a major procedure, you'd come in 2 days before. 15 years ago, the night before. You'd meet, you'd think, you'd do that, and you'd have your procedure. Today, if you're 85 years of age and you live in Swan Hill, you go to the Royal Melbourne Hospital, you're invited to come in at 4 in the morning. Doesn't matter about other conditions, and just get in there and get out with the hope that nothing goes wrong. And most of the time, nothing major goes wrong, but there's always a little bit of a thing. We're going to hear, I understand, from health economists, we've got problems with funding arrangements. I believe there are problems with the electronic medical record. But one thing I want to say is, out of this crisis, we have got to do stuff differently. One fantastic thing the Victorian government did after a lot of negotiation and encouragement was to get primary care general practitioners to vaccinate people for COVID-19 in their community, in their cultural groups, because we weren't getting the patients and the doctors and the vaccine all in the same room at once. And the sales pitch was, it's an investment. By paying into a practice to do that, $5,000, that meets, and then vaccinating 50 to 150 people, that's one admission to one intensive care unit. So Australia has done extraordinarily well, and in our circumstances today, related to the pandemic and COVID-19, and we look very good, our mortality is fantastic on a global scale, but believe it or not, we're not adequately vaccinated. We've got about the best in the world, it's not enough. We're in the middle of a federal election campaign, as we've heard, and I have heard nothing related to healthcare, and yet there's a fundamental expectation that the federal government works kind of in private, general practice, private specialist practice, and the public hospital is supported by the state government. And it's almost as if they're black and blue, two completely different colours, different things, but it is so interwoven. So we need to do something differently, and I think it's to start exploiting the digital technologies, the outreach. We need more bricks and mortar, and it's not just the infrastructure, it's got to be the population or the workforce to support that, and it needs to be in a ratio. So technically I'm only interested in doctors. If you review what I've said, I'll refer to healthcare workers, because for one of me, you probably need 16 nurses, 2 radiographers, 8 physiotherapists, and so it goes on. And it's got to be in a coordinated balance. I'm very supportive of the concept of recruitment of healthcare workers, as has been advocated in the budget, but it's not helping anybody tonight. And I can assure you it's a crisis tonight, and part of it is there are the wrong people in our acute, tertiary type metropolitan public hospitals who don't need to be there. But they are, and it's a failure of the integration between management from the federal sphere and the government sphere. So they're essentially hotel requiring people, but they're not getting their assessments, whether it's NDIS, For residential aged care facilities, 900 people are sitting in your hospitals, literally, well, perhaps they're semi-recumbent, but that's all they're doing. And it's okay because the nursing staff are looking after them, but they don't need to. They should be looking after a different type of patient with those infrastructure resources. It's very, very complex. We had surge capacity management, and so a lot of industrial terms were kind of thrown out the window, and that was a good thing. It's a good national or state-based thing to do for the workforce, but enough's enough. I'm aware of medical staff and nursing staff and allied health staff, particularly in emergency departments, being physically abused, being mentally abused, and I can understand it. If I had a bone sticking out of my leg, I'd be sore and I'd be angry, and what do you mean I've got to wait 15 hours? But there are so many things, there are so many moving parts, it's almost too daunting to contemplate. But I think we can get there, but we have to do stuff differently.
Thanks very much. Angela, if I can, having sort of heard from Kirsten and Roderick about the pressures that the systems that workers are under and what they're facing, what do you think is confronting the system, and how, at a system level, do you think government needs to think about, and players within the system itself, not just the responsibility of government? How do you think we need to think about these issues from the perspective of a health system?
First of all, thank you to both of you for what you're doing. I can't imagine what the last 2 years have been like, let alone... Sorry, that's not working. Let alone continuing to work in this crisis environment. And we are in a crisis, and it can be difficult, I think, in a crisis to then think clear-headedly about, well, what are the systematic issues behind that? Where I'd go to is, let's go back before the pandemic. These aren't new issues. The pressures were building in our hospital system. The funding system here in Victoria, the case mix system, was broken, and I think we just need to acknowledge that. Most hospitals in this state had moved to block funding even before the pandemic. That is, case mix funding wasn't adequate, and so they were getting top-ups. It's effectively block funding. So the system was already not working. We already had the issues in terms of the NDIS that you pointed to, and that fragmentation where we're seeing delays in terms of, someone has a major trauma or a major deterioration and there's delays in the NDIS assessment, people stay in hospital rather than moving out, and that creates problems throughout the system. So that's definitely one thing where I think the Commonwealth in particular can really step up and take some pressure at this critical time off the hospital system. But again, these are big issues between the state, the federal, the doctors, the nurses, around the general level of fragmentation of our system between those levels of government, where we see responsibility, particularly for those with chronic diseases and quite complex chronic diseases who cause a lot of the demand in our system. So they're the long stayers, they're the people who come back regularly. And what we see is that funding between, the public hospital system, because they have a lot of involvement from those specialists, and the federal government, it isn't adequate really to cover those patients, and you see there's gaps in that care, and so people end up coming back sicker and more regularly. So that's one area, I think, of reform. Then there's private versus public. And I think that is, it's a difficult conversation to have, and perhaps one that's more political. But the private system is there, right? It does have capacity. And when I see a public system near breaking point, and I see a private system not near breaking point, in my head I think, well, what's going on there? Why are we creating these silos between public and private? And we're not thinking about the capacity across the health system, having a bit bigger thinking, not so based on politics in terms of, and how can we use that capacity as well to alleviate some of that pressure? Because we can't expect our public physicians to continue to operate like this. It's not safe. Care isn't safe at the moment, and we have a private system that we could be utilising more, whether that's around elective surgery, whether that's around moving some of these patients in terms of the NDIS, whatever it is. Let's take away our sense of we can't possibly think about this system as a whole health system, and how it can be best serving our community needs. So that's in terms of where I think we need to be thinking about some of that big system reform. And I'll stop talking because I could actually go on all day.
Thanks very much. Whoa, here we go. It's raining microphones. That's good. Brett, from you work a lot with healthcare professionals trying to figure out how to make their lives a bit easier through better using technology. Having heard what you've heard here and from the work you do more broadly, what do you think we can do to make, whether it's nursing staff or other medical staff, and there's a phrase that Kirsten used, giving them more time to care. What do you think we can do to facilitate that?
So that's a great question, and I guess also thank you to all the healthcare workers out there, especially on International Nursing Day as well. I guess the perspective I can give is in terms of the technology trends that we see, and I think the technology trends that we're seeing and the requests are very similar to some of the topics we've spoken about. The most common areas that we're seeing is interest in patient safety, a lot of interest around how we can actually help with the well-being of healthcare workers, because that's clearly becoming a challenge. We're also seeing that there's a lot of move to how we can help to safely support people that are maybe treated in their homes, which is kind of topical of what we've covered. We're also seeing, I guess, some interest around the likes of supply chain and asset utilisation as well from a technology perspective. I'd like to give a little bit of context of where I'm going to go with this in terms of who Zebra Technologies is, and I don't really want to talk too much about Zebra because this is more about healthcare. But Zebra Technologies is a company that is often not well known, but if you look out there, you'll find that we're pretty much everywhere. We do a lot of work in various industries. If you've been at home, you've had a parcel delivered by Australia Post or another global transport company, if you look closely, you'll see it's a Zebra mobile computer that they're using to do that delivery. We do a lot of work in that industry around helping to provide visibility, help the staff that are actually doing the deliveries and have full traceability through their supply chain. If you go into your local supermarket or one of the major retailers, likes of Woolworths or Wesfarmers, and again, if you look closely, you'll see it's a Zebra device where they're trying to use those to improve the way in which they work with customers coming in, and they want to make sure your everyday shopping items are there to be used. So that might give you a bit of a context of who we are. I'd certainly recommend that you look the next time you're in a retail store or you're getting a delivery. It becomes addictive, especially for our team as well. We may well be the biggest company that you don't know. To give you some context of our size and who we are, we've been around for 50 years. Our global sales is around about 5.6 billion. We've got almost 10,000 employees across 55 countries. And the reason that we're not so well known is because we focus very hard on purpose-built devices that actually suit the needs of each individual market or customer. So for healthcare, what we've done is we've actually added the capability to all of our devices so that they can be cleaned down very, very effectively by all of the cleaning agents you may use in healthcare. So there's no risk of spread of bacterial viruses, which is really important when you're getting people in for care, and especially if you're looking at the safety of patients, because you really don't want people going into hospital and coming out with something else. So that's actually one example of how we try to customise to meet the market itself. The other thing that constantly surprises us, and coming from that bigger, broader market, is that we often are surprised that an apple that you might buy in your supermarket has more visibility, more traceability than a lot of the medicines, patients and assets in a healthcare facility. And that often seems quite crazy. So one of the things I did want to talk about, and this is something that we're seeing more and more, and I think somebody touched on Scan for Safety earlier, is that in the UK, our UK colleagues have supported the National Health Service in a Scan for Safety program. And that's a program where they're using GS1 barcodes to be able to provide traceability of patients and their treatments, their assets and their utilisation, Catherine Coates from GS1 is here today, so if you do get a chance, worth having a chat to Catherine in more detail about that program. But that had some amazing results. But there's a quote in a report, which we can share later on, which basically states that they set out to try to improve the system to be far more efficient, but the most surprising result that came out of it is it had a drastic improvement in patient safety. And those same technologies can make a big difference to the well-being of the healthcare workers because they free them up to be able to spend more time with patients. It gives them the ability to communicate and collaborate with the other workers around them. And it takes away a lot of the anxiety of administrating medicines because you know it's precisely tracked, that you're giving the right medicine to the correct patient as you're delivering it. So I might leave it there because I know we're running a little bit over, so thank you.
Thanks very much, Brett. There was a lot in that, from, I suppose, some of the macro issues to some of the micro challenges. A fair few ideas and solutions in it as well. Fair to say, I've got a list of questions that could probably take us for the next 3 or 4 hours, but that is not my intention. My intention from here is to get a conversation going. So I'm going to say there are microphones on your tables, or there's probably one now, microphone on the table, given I appear to be hogging them all up here. So if people have got a question that they might like to ask, have a think, get ready. I might kick things off here with a question to the panel and then throw to you out there to have a say as well, because I think these threads of what we see the challenges are, and they're very, very clear here in that there's both the issue of burnout that Roderick talked about, the issue of increased sort of demand and expectation about the services that people want to be receiving in our hospital systems that Kirsten touched on as well, and how we take those through to figure out how we make the system better. Because I think, and one of the points that Angela made about there are opportunities to think that, well, 2 things I think taken from her conversation. One is that the system was under a hell of a lot of pressure prior to the pandemic anyway, and the pandemic has just made it a bit worse, a lot worse. But also that we probably need to rethink some of the ways that those systems interact, the public-private point, how we do some of those funding issues. So there's a lot in that. I'll start with a question riffing off a comment that Roderick made, that we can't let the crisis go to waste. Because I think we've got an opportunity. There's clearly an opportunity, given the salience of health as an issue for the state government. I think you don't need to be a political expert to understand that the state government in its recent budget understood that health is as a major issue here in Victoria, and that there is 6 months to a state election. So there's clearly, it's on the minds of our local state leaders. I think there's a question about how much it's on the minds of our federal leaders at the moment, but we'll see how that plays out over the course of the next 10 days. So my question really is, what do we need to do differently so we don't let this crisis go to waste? What do we think is the key issue that we've really got to pick up and run with? All of you, but you could absolutely start if we can.
Yeah, what can we do? I mentioned something that was completely revolutionary, and that was the state government investing in primary care. Never been done before. The expectation would be just try to get people to go to their GP and all that sort of thing. But also, we've discussed the many moving parts, but they're moving at light speed. So when the pandemic was first discovered, people in my job were dying. And so I was pretty nervous. I was 6 months away on the other side of the planet, but I was pretty nervous about what was going on, and a strong advocate for vaccination. For 100 years, we've vaccinated, or thereabouts, against stuff, and it works. And then it depends if I'm in the emergency department, I am in the operating theatre, I am in the intensive care unit, if I'm in primary care. And there was this raft of views, personal opinions, where everybody was in their practice of medicine. And they didn't know if they're in primary care, the person coming in the door was the most rabid anti-vaxxer and going to cough in their face. And guess what? Even in Melbourne, we've had examples of that. You know, rare, but you only need one. And if one person in this room has COVID, asymptomatic, they don't know it, we're all going to get it. If we haven't had it, of course. I'm already meeting people in the medical and healthcare workforce and in the community who've had it twice. You know, how greedy. But this is what's going on. And so nobody knows. So you look after yourself. The federal government, 0 out of 1 million in providing primary care practitioners, and that's all healthcare workers, medical, nursing, people going into people's homes with personal protective equipment. Like, unbelievable. The state government, not covered in glory, because I had conversations, and they said, of course, this is the gold standard, and you have to do this. And they go, my God, we've got 3 hours of equipment. You don't have to do it anymore. So Kirsten and I are working in a ward environment, and we had much less protection for ourselves, knowing that we're walking into somebody at this stage. They were diagnosed with a very aggressive form of COVID-19, the early alphas and betas, and we had less protection than the guy sweeping a hangar or a factory floor in case a bit of dust came up. Okay, so that's kind of the environment, but it's moved, and there's better protection, there's better opportunity, better investment. But it's not flash in primary care. They've had to look after themselves. They've had to go to Bunnings and buy whatever they could find on the shelf. And even then it's pretty ordinary. So we have to not discard these. And interesting, if you go back 100 years, look on the library shelves, blow that, another form of dust off, it's all been done before, and we've ignored it because we want to. Today, or earlier in the week, I read a newspaper article. Time to get out there. Go to the movies. Here's the best movies to see. Go to the movies, you're going to get COVID. Get on the train, go to the footy. And so in the healthcare workforce space, we're not dropping like flies, we're not dying, but we are getting sick. And many of us have children in primary schools. The education system is out of control. The business community aren't interacting. I have had 0 conversations with anyone in business. I hear them on the TV, catch a plane, do this, go out, go to dinner. And I've had no conversations with education. And I can tell you, in the particularly primary school classrooms, a child here gets COVID, goes right around the room, think of it, one big table, comes back, they get it again. And the teacher is under a bus. Who cares? The teacher goes home to Kirsten, who then gets it, furloughed from work. Kirsten or I don't turn up at work. And so the cycle just repeats. And there's nothing more important in Melbourne today than going to the footy. So that's the problem that we've got. 2 universes. So the good news is the whole theory about the multiverse is correct. There are 2 of them in Melbourne, in Victoria today.
Kirsten, if I might just ask you before I go to the floor, what do you think we need to do differently? Like, out of the experience that you've had, what is it that you think we could change in healthcare, big or small, that would really make your job a lot easier?
I really think you really need to ask nurses what they need to do their jobs correctly and properly. But also there needs to be a big investment in terms of money, in technology that helps us, enables us to do our job properly. So would be device integration, all these things that would free up me to actually provide that care. But also our hospital that I work in, and I've worked in for a long time, we've transformed some of the ways we care for children, but we haven't transformed all of them. So we moved swiftly to telehealth, really swiftly in the pandemic because it forced that. And then we stopped with our transformation. I was thinking, oh, this is such an exciting time to be a nurse. One, I'm seeing this transformation of care. We're providing care in a different way. We're moving children more to hospital in the home, but then we've really stopped and we've stalled. It does take money and investment, but it takes that insight and that you have to be brave in a way, How can we deliver care differently that's not in a hospital, but how do we enable nurses to be leading that care? Because it is important for nurses to lead care, and we know we provide good quality care. But how do we engage nurses in wanting to be involved in those strategies? I don't think we're ever asked, really, sometimes. From a hospital perspective, yes, I'm a clinical nurse consultant. I lead EMR from a nursing perspective alongside a CNIO. But we can see all these opportunities in the hospital to use informatics and our EMR to improve efficiencies, but we fight to get those happening. We had to go to a foundation to get funding for our handheld device. How can that be sustainable for care? The nurses need that to deliver their efficient, safe patient care. We had to go to the foundation to get funding for that. You know, we were using a device from 2016. No one uses a mobile phone from 2016, but we're expecting a nurse to use that device to deliver safe medication administration. So really, I think we need to look at the resources we have. We need to have more vision for nursing and efficiencies and nursing models of care, patient care, to create capacity in the system.
I think that's really interesting. I think that vision and combining the vision that we want to have with this moment where fast transformation and accelerators of change have really come to us, we can harness the good part of this experience and demonstrate that we can actually change fast when we need to, so long as we're changing in the right way and heading in that right direction. Yeah, of course.
Don't need to all of the time. I guess just to really put it on the record, there are several things going on at once. And so there's what's happening right now. The Victorian budget is looking into this sort of 2 months to 4 years period, and it really needs to be reproduced, but you betcha everyone else is going to have a crack. And I've made the point, we do need infrastructure like railway lines, but if you're not well, you can't catch a train. Okay, so it's got to be a balance. Now, there's no question we support the industrial instruments that are around, and people need to be paid proportionately, and someone needs to recognise that nurses and school teachers are completely underpaid relative to their contribution to the community. And then what's happening at the moment is a massive problem in the public hospitals, all of which have an emergency department. So it sounds like Kirsten's environment, there will be a 1-to-4 patient ratio. And that's very supported for all of the reasons it's very supportable. You go down to the emergency department. I haven't been recently into the Royal Children's Hospital, but I work at Monash Health, and there's a similar sort of children's hospital there. And you will have heard in the media this week, there was a very unfortunate event for an 8-year-old girl. That's the place where I work. Now, what happens is in the emergency department, the nursing ratio is kind of 1-to-35, if you're lucky. And what we need to start thinking about in the immediate term are some shorter, sharper changes. So if I've hurt my ankle and I'm sitting in a wheelchair in the corridor being screamed at by a psychotic patient in the emergency department, I'm in the way. I could actually sit in my wheelchair up in Kirsten's ward, because I'd still be in the way, but I'm not causing a 1-to-35 patient ratio in the emergency department. And that's when you're in the emergency department, because today every major emergency department has 15 ambulances outside with 1 patient in there, 2 ambulance officers. There's actually one and a bit ambulance officer because they're doubled up and volunteers and all that sort of thing. So this is good crisis management. It's what you'd want for the community to pull together. But if you need the next ambulance, you can't because they're parked outside the emergency department and nobody knows that you're there in the back of that ambulance, let alone that you're dying, because we've had a few episodes of that as well. And if you say, you're advised now it's going to take an hour and a half for the ambulance to turn up, so you get your neighbour or your partner or a family member, drives you there, and you're in the waiting room. The waiting room is invisible. Nobody knows you're there. And for example, if there's 8 children who are 8 years of age, how do you find the one who's dying? Because you haven't even assessed them. We haven't called Kirsten down from the road to use her years of experience to say, That's a sick kid. Bring him in. So these are the problems. So there's a problem tonight, there's a problem in a month, there's a problem in 2 years, and the budget, the Victorian government's budget, is looking to address into the early, medium, late, short term. We need to find something today, and an EMR is not going to cut it. We need more help, because every time the healthcare worker has their own mental health processes, and every day someone says, I just can't do this anymore. This isn't what I signed up for. I know I can do a whole lot better with the appropriate resources, and this is just not what I want to be part of, and I need a break. So we need to do something for tonight as well.
Second one, yeah.
I think, is it working? No. I just wanted to jump in before we go to the questions with something maybe a bit more positive in terms of what we learnt from the pandemic, which was, I think the big success was that hospital in the home program, where we saw, it saved our hospital system, let's be honest, and also in New South Wales, and it was trialled here in Victoria by the Royal Melbourne Hospital during the 2020, and so put up my hand and go, very proud of that, and the team there that did that. That really is, I think, one space where we learnt a lot about how we can increase capacity. I would stop, and this is a thought in terms of how we're rolling that out going forward. So at the moment, I think the strategy is that every hospital sort of has this program. That's relatively inefficient. There are hospitals in the US that are actually all virtual. So you can set up a virtual hospital where you gain the expertise in terms of, because the nature of care is obviously different, the things you need to think about are different. And I do wonder whether, yes, Royal Melbourne Hospital did it very well, led by, let's be honest, some of the world leading emergency physicians globally. But when you're asking for smaller hospitals to do that, whether that type of rollout in Victoria is going to get the same benefits, or whether we need to be thinking, is the next hospital in Victoria a virtual hospital? And so we think about the expertise that are behind that and how we might roll that out, how that may then integrate back to the hospitals where people are potentially being discharged from. It's not to say it's not complex, and as I said, it's possibly a bit of a big idea, but I think at the moment it always concerns me when we do IT at this really granular level. You're asking a lot of individual hospitals to carry that implementation, and it is quite, as we know, anyone who's been involved in an IT project knows, it's difficult. Whereas if we looked more towards centralising that expertise, it might actually deliver a better outcome and more world-class care in terms of this hospital in the home.
Thanks, Angela. I did promise questions from the floor, so I will open it up if people have questions. We've got one microphone and a couple of microphones here. We'll figure out how to get them. If you could just introduce yourself and then ask your question, that'd be great.
Hi, everyone. Thanks for being here today. My name is Lisa. I work in political and economic affairs at the U.S. Consulate. And you just mentioned the United States, an all-virtual hospital there. I was wondering what other jurisdictions, whether it's in Australia or around the world, do you see having models that are worth emulating? And then another question I have is around the really contentious conversations or conversations that aren't had between people who have different views about vaccines and vaccine mandates. I know in the United States that's raging, and here as well, and it seems like there's a lot of people just digging their heels in more to their different perspectives. So what are concrete actions we can take to move the conversation forward in a productive way, and people who do have skepticisms to answer their questions, talk about scientific debate productively. Thank you.
Oh, that's a hard one.
You can do the first half first.
I think, there's obviously globally, and pointing to the US is interesting, isn't it? Because I think as Australians, we often look at the US and think, oh, they're nuts, right? I mean, let's be honest. And who would want to emulate their healthcare system? Because, they spend so much money. But there's a lot of innovation in the US. It's very expensive and it costs them a lot of money, and, they probably over-service and all those sort of things. But I think it is useful to look to there to see, well, what is best practice, what's actually worked, and certainly, there's a lot of innovation. Israel has also, I think, is, sort of at the cutting edge of the hospital in the home type rollouts, and has a very good healthcare system. So certainly there's examples overseas that we can look to that are doing this well. The vaccine question. Look, I'll be honest, I probably am not the person to, I avoid these, I've got friends who are obviously vaccine hesitant. It's difficult to engage. I think it's important not to demonise people, to understand fears, to empathise with those, and to point out, the factual, sort of the logical implausibility of their claims. But it's difficult. And I think, going forward, this problem is not going to go away. As I said, we need people to continue to be vaccinated to stay protected, and probably increasing and being vaccinated now for flu as well, because our health system simply can't carry this surge of hospitalisations. So, yeah, but I'm not a...
Briefly touch on that second point.
Yes, thank you. So I'll repeat what I said. The vaccines have been revolutionary in our ability to manage COVID-19. Now, so there's a couple of legs to your very reasonable comment. So absolutely, in the ideal world, I would sit down with a person for 4 hours and run through everything. I haven't got 4 hours. The pager goes, and that's the difficulty. What I can assure you, I've managed the patients who, didn't want on the death certificate it was COVID-19 because they just didn't believe it existed. And part of that is the social media phenomenon in which we find ourselves, and people becoming engaged in black rabbit holes or all that weird sort of stuff. So if we had the resources and the time, we could sort of work our way through. Now, we have to be very honest. Some people got knocked around by the vaccines. And as a consequence, many people have had the 2 doses, which we ludicrously call fully vaccinated. Like if I'm going to drive to Perth and I fill up the tank and it's empty by the time I get to the South Australian border, I can't think, well, I had enough petrol to get me through to Perth. And that's the problem. The early vaccines, the way the coronavirus works with our immune system, it wanes. That's why I say if you've had COVID, you might have 4 to 6 weeks of relative protection. You can probably still spread it, but you won't be that sick. So I'd love to go through and have the luxury of the time to go through all of those things, because some people had a bad experience with the 2 doses, the booster, 3rd dose, they didn't want. And I'll repeat what I said earlier. We've got a phenomenally good vaccination rate. It's about 66% or 2/3. It's just not good enough because it's still whizzing around. Today, influenza is absolutely bashing the system. And so we have to encourage people to get the flu vaccine. The same people are often prepared to have the flu vaccine, but they don't want to have the corona vaccine. If I was a citizen in the United States, I'd be eligible for a 4th dose. But I'm not, because I don't fit the criterion in Australia. But I'm looking after the people in the hospital, as is Kristen, who are presenting to the hospital with COVID-19. And I know that when I got my 3rd dose as early as I could, because I was in that environment, my protection has waned. I don't qualify in Australia for another dose of the vaccine. And these are some of the difficulties related to right now. And there are people in my circumstances who say, I think I'll take that long service leave, which just means those people who are left have got a little bit more of a burden to deal with. Lots of moving parts. It's very, very complex. And we have so much information streaming. And the confusion, as I said, from business, restaurants, travel, hospitality, feel for them, but it's a completely different message to the healthcare universe.
I might just add to that first question. So we actually see that the UK health system has a lot of similarities to Australia. They've got the National Health Service there. And we do a lot of work comparing notes with our colleagues over there. There was a campaign called Scan for Safety that they ran a trial on across 6 of their hospitals. And they've recorded some really good data around the improvements in terms of the way they operated, their ability to save money, which could be freed up for other areas of healthcare, and also the improvement in both patient safety and the well-being of healthcare workers. We can reference that, and GS1, Kath, who's actually on the same table with you, can maybe talk a little bit about some of the reports that are there. But we often do look to the UK because there's a bit more of a similarity to the Australian healthcare industry versus the US, which is quite different.
I might just get last question in the front.
So hi, I'm Alana Phillips from Organon, and I'm a medical advisor. So I just remember you talking about GPs being given the opportunity to do the vaccines for COVID-19 and taking some of the burden off. Primary care is also overwhelmed at the moment. So I wanted a perspective from both, the AMA and, a specialist as well as from a nurse. What are your thoughts with regards to task shifting other things? For example, if I think about in the context of contraception, perhaps LARC insertion, for the nurse to do that as opposed to the primary care physician, to free up the primary care physician to deal with other more challenging elements of care. So I'd like both the nurse perspective as well as the perspective from a specialist.
Oh, I can really talk from a hospital perspective when we refer patients back to GPs, for example, for wound care. There's very competent practice nurses out there and practices where instead of us referring them to a GP for wound care, we could be referring them to the practice. But what's happening now is that people don't have GPs, so we can't refer them back to a GP for that wound care, so they're coming back into hospital. So how do we really have that nurse-led model of care, whether it's in hospital, in our outpatient departments, that stops us taking up the resources of the physicians or our clinicians, but also how do we engage with local practices to provide that care? Or we used to have district nurse, like that was privatised. We used to send district nurses out to provide wound care. Can that be part of our hospital in the home or our virtual care? From a paediatric perspective, we have parents that are capable of caring for their children. They care for their children every day. We used to teach them how to do wound care. We don't do that anymore. And I think we really need to look at the resources we have and use them much more wisely, but it has to be a shift in our thinking. Why is it the public hospital providing all the care? Where else can we provide that care for those families and children?
Thank you. And I share the view. So interestingly, in many ways, what you've described is occurring, but the structural barriers to prevent that are broadly unbelievable, and you're kidding. So there is the opportunity to do it, and if you have a large enough enterprise, the primary care groups can do exactly that. So it needs to be a team-based approach. And there is no question, say AMA Victoria as a policy is very supportive of all of these outreach programs, particularly in mental health, but also for the physical health as you've just heard described. Through the pandemic, a lot of people have met a GP for the first time because they've come from places where what's a GP? I'm sick, I go to the hospital. And so that even that's been missing. So we'd hope those relationships continue. But equally, the GP doesn't have to do everything. But politically, I argue that there needs to be the engagement. So it's a team-based approach. It's a mini version of a hospital. I mean, it's not so hard. But the funding is catastrophic. So I can't give you one of those procedures unless I give it to you. I can't charge for any of the consultations in primary care talking about I'm worried will I have the third dose, the 18th dose of a vaccine, unless I'm eyeballing you. Now, that's been a bit relaxed, related to digital and best visual, and they're great adjuncts, and we should be capitalising on all of that. But they're not the full answer. You know, sometimes you've got to put a hand on a person and say, yep, that's a real hard lump, we better do something about that. So it's just sitting down and sensibly building the structures to provide the healthcare that we want. Because last time I looked, it's well into the 21st century, and we're still sort of kind of the Dickensian type of approach. Time to move on. So we can capitalise on all of the digital media and opportunities, the data gathering and all of that, but you still need to have one-on-one communication. So some entrepreneurial types are attempting to do this, and that's what I said. When I deliberately said that the Victorian government funded practices to do the vaccination, they didn't pay for the vaccine, they didn't pay for that. They gave a dollop of money as the investment because it's illegal. And when I'm a patient enrolled in a hospital in the health program, our Prime Minister got up and said, oh, you got COVID, tell your GP. Well, the GP actually didn't want to know because what are they going to do? Thanks for sharing the news. Because you're a patient of the public hospital, Medicare agreement, out of date, but that's, you know parentheses, you're funded from the hospital. I go to jail if I charge you for a consultation. And, you know, that's the environment. It is bananas. And so it goes right back to my early statement. This is an opportunity to really rework the system, which is what is required. Get the right person, the right place, the right environment, the right infrastructure to give patient care. That's what we're all in it for. You know, the clinicians are in it for.
All right, we are out of time, but Darren, last question very quickly, with a very quick response.
Very quickly, we've had a virtual Prime Minister for much of the last 3 years. How do we use, given the hesitancy, people said, effectively a lot of people said no to electronic health records when it was opt-out, vaccine hesitancy, even climate change, science itself, people seem to question. How can we use technology to convince people that this is actually the way forward? Because it seems like there's a bit of an impasse of really polarised opinions of believers and non-believers. How does the medical fraternity embrace that, and how do we use that as the next frontier?
Anyone?
I'm sorry, I seem to be speaking too much, but it is tricky. And it's a continuous process. So certainly within medicine, you throw out a hypothesis, you do an experiment, you see what's going on, you analyse the results, and hopefully you're very honest about what that is. And this is working, this isn't working. Gosh, look what happened when that happened. And so you pass it, and then you present the information, because fundamentally you're responsible for your body. I can tell you the best technique for whenever you have anything, and then I'll start telling you what the risks are. And guess, out of the two of us, who's taking all the risks? So it really doesn't matter at the end, provided all of the information is accurate. And there's the rub, because a large part of the time there's complete bunkum, complete rubbish coming from, you know, Kevin in Alaska. Like, you know, why are people in Wantirna listening to Kevin in Alaska? You know,
From Brisbane.
Possibly. And so it's ultimately you provide the information. And look, I've met an awful lot of people, managed them for COVID-19, passionate anti-vaxxers, influencers, the whole thing. They've had it, they completely changed their tune, okay? And that's a terrible thing for anybody. I don't wish it on anybody, but when they go, Kevin lied to me, it's a revolution.
Yeah, so I think the core for technology for any solution is making sure that there's visibility of how it's going to help. And I think visibility and sharing information is probably the best way to communicate how you're going to make those improvements. However, social media may be a challenge for that, and we certainly don't have an answer for that one today. But I think overall, just making sure that there's that sense of what you're setting out to achieve when you're putting the technology in, the visibility that it's working, and making sure it's well supported. And I think you touched on IT projects being challenging. Generally, in our experience, that's more about making sure that the right sort of consultancy is done first, make sure it's a proven solution, and making sure that there's a support system that's set up as well, which is certainly a trend that we've run into, is that there's a lot of systems out there where service and support is actually an afterthought, and then that becomes a real problem once the project's deployed as well.
All right, we are absolutely out of time here today. Sorry, Angela, I can't let you say any more. Thank you all for joining us. On behalf of the McKell Institute, I really wanted to thank you for coming and participating. These conversations only work when people come and listen and engage, and that's really what makes our job of stimulating debate about important public policy questions a whole lot easier, is people like yourselves turning up. We'll have more events over the course of the rest of the year, so please make sure you stay tuned to what they may be. I'd also like you to join me in thanking our panellists here today, to Kirsten, Roderick, Angela and Brett. Great conversation, interesting topics, some challenging views. So we really appreciate you all here. There's some sandwiches left. Please make sure you eat them, and we'll see you all next time. Thanks very much.